is Dr. Eslam Ramadan. He's an anesthesia fellow in the liver transplant and hepatobiliary surgeries. Dr. Islam has an MD, DESA, EDAIC, FCAI. He was an Airway fellow, anesthesia department, Beaumont Hospital, Dublin, Ireland. He's a college tutor for final year medical students, an Airway instructor in Royal College of Surgeons in Ireland, RCSI. He's a lecturer also in Ain Shams University Hospitals in Cairo, Egypt. He has a special interest in airway and paediatric anesthesia. Dr. Islam will be giving us a lecture today about obstructive airway management. And the mic is all yours, Dr. Islam. Thank you very much for your great time.
Please, thank you so much, Dr. Enas.
Okay.
Thank you so much for your...
Please after your lecture.
Yeah, okay.
Go ahead, Dr. Islam.
Thank you for your lovely words and your introduction. And I want to thank all the committee behind the mega course who give their time and effort for this course. And I'm honored to be a speaker in this course, really. Thanks for all of you. So I will share my slides here. So our lecture today is hot topic talking about management of upper airway obstruction. So hot topic during the exams and also in our clinical practice. So the objectives of these lectures will talk about decisions when and how you will do intubation for upper airway obstruction and what other alternatives for that. Airway assessment, quick review for that, and some definitions about it. Systematic approach of management of airway obstruction. And these 3 points will go through a case scenario to make it more interactive. And at the end, we'll talk about briefly about the guidelines for awake tracheal intubation 2019 and can't intubate, can't oxygenate scenario and the front of neck airway access. So if we talk about this case, imagine you have been asked by the A&E registrar to review a patient in the recess, 66 years old woman who is presented by difficulty of breathing and stridor, with history background of obesity, high BMI, COPD, and pharyngeal squamous cell carcinoma. So what is your reaction and what is will come in your mind while you are going to check this patient? Of course, all anesthetists, when they hear stridor, you have your heart rate will come up and you will be more alert and worried about the patient. But anyhow, as we said, this is one of the most frightening situations that the anesthetists may encounter, really. And I want to emphasize that there is no universal guidelines or best approach for management of upper airway obstruction. Your management will depend on answering 2 questions: is when I will secure the airway. Is it an emergency that I have to do it in the A&E or in the ward, or I have time that I can optimize the patient, I can shift the patient to the theater. So it will guide your management for this one. The second question is how I will secure the airway. So is it a conventional induction and intubation, or I will do awake tracheal intubation, where the patient will need tracheostomy? Usually, you always put plan A, plan B, and plan C for your patient. So intubation is based on 3 fundamental clinical points. All of us will know about this one. The first question is there a failure of the airway maintenance and protection of the airway, like low GCS less than 8, in traumatic brain injury or in intoxication? Is there a failure of ventilation and oxygenation, like status asthmaticus or COPD exacerbation? And what is anticipated clinical course? And this is very important and really depend on the experience of the anesthetist. For example, like stab, neck wound, polytrauma patient, angioedema, and burn. Those kind of patients can be presented in the A&E asymptomatic from the airway point of view, or mild symptoms, but suddenly they can be rapidly progressive and you have complete airway obstruction. So you have to be ahead of them and anticipate the progress of this disease. Any actions are required before performing actual intubation. So you have to, according to your assessment for the patient's need of intubation, as we discussed in the previous slide, and the urgency of the situation. Determine the best method of airway management based on your assessment, and we'll discuss this one in the coming slides. Decide what pharmacological agents are indicated, what order, uh, what doses you will use, and prepare a plan in the event that the primary method is unsuccessful. And this is a very important point. And this is my advice for all the attendees, that you usually have plan A and plan B if the plan A is not working. So how to approach the patient or your assessment? So the first thing, be sure that there is an airway patency, and this can be confirmed easily by asking the patient, "What's your name? Do you know where are you?" If he's answering, he has a patent airway. Assess your airway. We'll discuss this one in the coming slide, but quickly, if there's like limited mouth opening, like short theromental distance, like this little microgantia and short theromental distance, limited mouth opening. Third point is to assess the ventilation, and this can be done simply by taking ABG to see the PO2 and CO2. Assessment of patient anticipated clinical course, as we mentioned before, like angioedema. This patient, of course, rapidly progressive. It will be a difficult scenario if you are going to intubate this patient. So in terms of airway assessment, there's some useful mnemonics for difficult or assess difficult laryngoscopy, difficult bimanual mask ventilation, difficult LMA insertion, difficult cricothyroidotomy. So if we go for the difficult laryngoscopy, we are usually we can use Lemon score. This is L for look externally, and usually if there's an official trauma, beard or mustache, big tongue or prominent incisors, and E for evaluation 3, 3, 2, 1. So 3 fingers here for the mouth opening, 3 fingers between the mentum and the hyoid bone, 2 fingers between the hyoid bone and the thyroid. And this 3-3-2 rule is to be sure the alignment of the pharynx, larynx, and the trachea. All of us, of course, we know the Malampati score, opacity and obstruction, neck mobility. Roman for difficult bimanual mask ventilation, radiation or restriction of neck movement, opacity and obstruction. This lady, you have to be sure that the mask to be fitting and seal on the face. Old age, no teeth, also all these parameters for anticipated or bimanual mask ventilation difficulty. Rods for difficult LMA insertion, again, radiation, opacity, distorted airway, short theromental distance, and smart for cricothyroidotomy, any surgery in the neck, mass, a distorted anatomy, radiation, or tumor. And this is an example. Of course, this case, it's nearly impossible to do any cricothyroidotomy or tracheostomy. It's a very difficult case. We have 4 key signs for upper airway obstruction. I don't want you to forget it, which is muffled or helping to voice, inability to swallow secretion, stridor, and dyspnea. These 4 key signs for upper airway obstruction. The first 2, it doesn't indicate that there is a complete or nearly complete upper airway obstruction, while if the patient is stridorous, be sure that there's more than 50% of the airway is obstructed already, and it's a serious condition. We'll go for some definitions. So if you ask me what does it mean difficult bag mask ventilation or difficult laryngoscopy, so we'll go one by one for this one, and there is no universal or total agree about these definitions. They are different in many literatures, but I pick the most common definition that we are using. So difficult bag mask ventilation is an ability of unassisted anesthetist to maintain oxygen saturation above 90 on FiO2 100% or FiO2 or difficulty maintaining mask seal and obtaining satisfactory end-tidal CO2 and tidal volume. The incidence of difficult mask ventilation is 1 to 2 per 100, and the incidence of impossible mask ventilation is 1 to 2 per 1,000. Difficult laryngeal mask ventilation, inability within 3 insertions place the laryngeal mask in a satisfactory position to allow clinical adequate ventilation and airway patency. And when we are talking about clinical adequate ventilation, we mean that tidal volume of 7 ml per kg and peak pressure not more than 15 to 20 centimeter water. And the failure rate of LMA is around 2%. Difficult laryngoscopy, it is not possible to visualize any portion of the vocal cord after multiple attempts by direct laryngoscopy, the conventional one. Difficult intubation is difficult, or failure of to do tracheal intubation, or tracheal intubation require multiple attempts in the presence or absence of tracheal pathology. We'll continue the case. So you went and you did your physical examination, which revealed that patient is somnolent but arousable, working hard, respiratory distress, supraclavicular and suprasternal retraction, and you can appreciate really high inspiratory stridor. And when you are doing your airway assessment, you have a limited mouth opening beside the high BMI. So we have many points here that indicate or predict difficult airway management, high BMI, limited mouth opening. You have a mass which led to respiratory stridor. And from this working hard criteria and somewhat expecting that the patient start to have some sort of respiratory failure as well. So we'll highlight some points on stridor, which is a harsh monotone airway sound produced during airway flow through an obstructed airway. Stridor may be high or low pitched, may be audible by bedside or need to be auscultated, and maybe inspiratory or expiratory or biphasic. Again, as we said, stridor, meaning to say that more than 50% of the airway is obstructed, especially in pediatric population, and anxiety, coughing, crying may lead to total collapse of the airway. From the pattern of the stridor, you can detect or determine the level of the airway obstruction. So if the patient has inspiratory stridor, most probably the obstruction is in the upper airway, as you can see here. While biphasic stridor, it is mid-tracheal, while expiratory stridor is lower airway obstruction. So to give you roughly where is the obstruction. So the causes of airway obstruction, we can classify it according to anatomical location, glottic and supraglottic, subglottic, and mediastinal or intrathoracic. And tumors like tumor epiglottitis, deep neck infection, anaphylaxis, angioedema, foreign body, and there's a lot of reason for this one. So you decided for our case to do an ABG, which revealed the respiratory acidosis with good oxygenation type 1 respiratory failure. Endoscopic examination revealed large friable mass filling nearly the entire pharynx and supraglottic area, unable to visualize the vocal cord. The patient is in a semi-seated position, working hard, in high flow oxygen cannula. Out of concerns of the upper airway obstruction and respiratory failure, you decided to secure her airway by doing intubation or securing the airway. I want to also emphasize about the endoscopic examination, or what we call nasal endoscopy. Usually in the elective list is done by the ENT or head and neck surgeons in their clinic if patient have any supraglottic or glottic tumor. But I recommend if anyone has a patient that presented by as an emergency of upper airway obstruction, or even in the elective list and suspect difficult intubation, it's very simple, just local lidocaine spray, nasal lidocaine spray, go by the fiber optic, okay, very gently, just to see the vocal cord and localize where is the mass, to see the size of the mass, that if there is any deviation of the trachea, it will give you indication about the success of the awake fiber optic if you are planning to do awake fiber optic intubation, or other alternative like awake tracheostomy. And this is the case, as you can see, this is a tumor, supraglottic tumor, and you cannot appreciate the vocal cord. So it will be very difficult, even if by awake fiber optic, this case. So to secure the airway, we have 5 principles, and you should keep them in your mind while you are thinking how to manage the airway for upper airway obstruction. The first principle, I want you to know that the clinical picture dictates your action. So don't wait until the patient is hypoxic or desaturation to let you decide to secure the airway or to go for intubation. Usually hypoxia is a late sign. So your decision should be taken upon the clinical picture of the patient, your clinical assessment, patient respiratory effort, and discomfort, and the kind or the pattern of the pathology itself. The second principle is avoid sedation and paralysis. So never take away what can be given back. It's critically important to keep the spontaneous breathing of the patient, not abolish it, especially if you suspect difficult intubation or back mask ventilation or surgical rescue for these patients. The third principle is keep in mind that surgical management may be plan A. It doesn't necessarily to be plan B after you failed in the intubation and then do the rescue surgical management. It can be plan A from the start. And it should be done in a highly equipped area like OR, skilled anesthetists with you, and contact the head and neck surgeons to be beside you. Principle number 4 is buy time while examining the airway, and it's very important because you will take time, of course, to prepare the difficult airway trolley. You will call for help. You will need the assistant with you. You will call the theater to prepare for the coming patient. So don't do all of that, and you are examining the patient as well. So don't do all of that, and you are leaving the patient as it is. No, you can do a lot of actions or procedures that can optimize the condition of the patient, give yourself and the patient time until you have a decision or management plan and prepare the environment for this. So what you can do, you can connect the patient to high flow nasal oxygen, setting up the patient, as we said in endoscopic examination for the vocal cord, transfer to high critical area like theater, put the monitor, consider heliox in upper airway obstruction. And it's very important to detect the cricothyroid membrane and to mark it. Even in theater, we encountered before many times that we failed to do awake tracheal intubation, and we know this is very difficult to do our conventional intubation. And the head and neck surgeons themselves, they are marking the cricothyroid membrane. Epinephrine nebulization, steroids, and reassuring the patient and decrease the anxiety. The fifth principle is intubation technique itself. Okay, so the decision how to secure the airway, it depends on it will go in 3 options. So the first option, you are using direct or video laryngoscopy with inhalation induction. So still you are keeping the spontaneous breathing. The second one is awake tracheal intubation, either fiber optic or video laryngoscopy, and again spontaneous breathing is maintained. The third option is awake tracheostomy under local anesthesia, and again the spontaneous ventilation is maintained. You don't want to be in a situation that you start IV induction, muscle relaxant, and you are trying to intubate the patient, you fail to intubate the patient, and of course, the hypoxia and desaturation will be a bad consequence. This is a protocol. I don't know if it's clear or not for all of you, but if we can classify the upper airway obstruction into 2 categories. The first category is patient that is already in like respect to arrest or about arrest, and you don't have any choice or you don't have any time unless you're doing considered rapid sequence induction, attempt the laryngoscopy. If you are able to intubate, well and good. If not, and in situation of can't intubate, can't oxygenate, you will proceed quickly for surgical airway. Okay, but if you have time and the patient is awake and breathing, okay, so your decision depends on your airway examination. So mild to moderate obstruction, airway obstruction, and you will be able to visualize the vocal cord by nasal endoscopy with minimal difficult airway character. We recommend to go for inhalation induction and using McGrath or video assisted laryngoscopy or direct laryngoscopy. But if mild moderate obstruction, you can still visualize the vocal cord, but there is a multiple difficult airway characters, as we said, like retrogantia, large tongue, difficult. The criteria that we said: difficult intubation, difficult mask by mask. So the recommendation here to do awake fiber optic intubation under topical anesthesia. The third category is severe obstruction. You cannot visualize the vocal cord, severe respiratory distress, and here you can go for awake tracheostomy under local anesthesia, like our patient. You will be able to visualize the vocal cord. So that's what we said based on the previous knowledge. The decision was to do for our patients awake tracheostomy under local anesthesia. and the patient transferred to the ICU for post-operative care after this one. So our usual post-operative management in the intensive care admission, routine post-intubation management like analgesia, sedation, chest X-ray to detect the site of the tracheostomy or the site of, or the place, the tube, ventilator management, blood gas measurement, and controlling the condition of the patient. And of course, if this is for further intervention like debulking of the tumor or remove the cause of the stridor itself. So the next two parts is we'll talk about the guidelines for the aortic tracheal intubation 2019. Um, Aortic tracheal intubation is considered the gold standard in management of expected difficult airway. The incidence of aortic tracheal intubation from all intubation UK is 0.2%, which is low, and because this incidence is low, there's a lot of factors. One of them is the experience of the trainee and the doctor of the aortic tracheal intubation, and the second part is the practice themselves. The key components of the aortic tracheal intubation is stop, sedation, topicalization, oxygenation, and performance. And we appreciate this. The S is small because sedation is not mandatory to do or to perform aortic tracheal intubation, especially if the case is an emergency, a morbid obese patient, not preferable to do sedation. So, as we say, sedation, aortic intubation may be performed without any sedation. You have to weigh between risks and benefits of the sedation. The usual agents we are using remifentanil infusion or dexmedetomidine infusion. Single agent strategy is safest for non-expert anesthetists. For airway topicalization, and this is the main part, and this is and really this is the most important part. Lead to successful aortic tracheal intubation. Lignocaine with maximum dose 9 milligram per lean body weight. Nebulized lignocaine can be used, but absorption is variable. There's a different practice about nebulized lignocaine. From my experience, and it's not necessary to do nebulized lignocaine. The most important is to the spray itself in the either nasal or oral, and to have complete block for the oropharynx and the glottic area and subglottic area. Glycopyrrolate around 200 or 300 mic can be given. It's better to be given around 20 to 30 minutes before performing the aortic tracheal intubation. It minimizes or decreases the oral secretions, which help to absorb the local anesthesia faster. In terms of oxygenation, there's a recommendation to administer oxygen during aortic tracheal intubation. It should be started as early as possible, the patient arriving to the theater. We recommend also the recommendations to use high flow nasal oxygen from 30 to 70 liter. The reported incidence of desaturation with this one is 0 to 1.5, is very low. In terms of performance, so selection of the endotracheal tube is very important. A lot of anesthetists they are not notice that how much is important this one, but the recommendation is to use a reinforced tube and stay away from our conventional PVC tube. The pivot should be directed posteriorly toward the posterior commissure of the vocal cord, and choose the smallest tube as much as you can for your patient. Patient setting up, most probably if you are performing the aortic tracheal intubation from the front position. Ensure the operator can see the monitor, screen, and pump, and there is ergonomics is very important during performing aortic tracheal intubation. Again, the aortic tracheal intubation can be done by fiber optic or by video laryngoscopy. After intubation, you have to check 2 points. You have to be sure that the intratracheal tube is intratracheal by visualizing the tracheal lumen if you are using fiber optic, or to visualize the tube going between the vocal cords if you are using video laryngoscopy. And of course, you have to see capnographic wave on the monitor. And I recommend all of you to have a quick look on the guidelines in details about this one. This is picture talking about the ergonomics of the aortic tracheal intubation. The operator is here, and this is the monitor for the patient. You can see here the video for the aortic fiber optic and the pump, so he can see the three. If he's performing the aortic tracheal intubation from back, again, the pump is here and the monitor and the video and the monitor in front of the operator. This is what we talk about: oxygenation, performance, tubicalization, and sedation. So complication and failed aortic tracheal intubation. So the overall complication is around 18% and mostly due to inadequate stop. Again, during the DESA guideline, you have to stop trying after 3 attempts and one with the most experienced and senior attempt. Unsuccessful attempt is defined by unplanned removal of the fiber optic or video endoscopy or the intratracheal tube from the patient. And there is algorithm you can follow in case of failed aortic tracheal intubation. Again, this is the complication, how you can manage the complication in the stop. So if there is a problem in the oxygenation, you can increase the FI2, change the mode of the oxygen delivery. I don't want to go in detail for this one, but just to have a look on this one. And this is the protocol in case of unsuccessful aortic tracheal intubation. The third point is the can't intubate, can't oxygenate, and fauna. So the can't intubate, can't oxygenate scenario incidence is 3.75 per 10,000 anesthesia, and therefore identify the incidence of emergency fauna as 1 in 12,500 to 50,000 general anesthesia cases in UK. It is a part of the DESA guideline for difficult intubation, Plan D, the cricothyroidotomy. So the most important part in the cricothyroidotomy or the fauna is to detect the cricothyroid membrane. So all days or before, you can detect it by visualizing the anterior neck skin crease, and it's effective in 50% of patients, which is very low, or the conventional palpation, and the successful rate is around 70% in non-obese, 40% in obese patients. And they recommended from the DESA to use the laryngeal handshake to detect the cricothyroid membrane. The fourth technique is using the ultrasound. We'll discuss now the laryngeal handshake technique. It's a simple maneuver that you put your thumb and your index finger on the greater cornea of the hyoid, then sliding down to feel the two sides of the thyroid cartilage, coming more down to feel the cricoid cartilage, and then by your index palpate in the middle of the neck to see the cricothyroid membrane. So here this one coming down, and by the index to check the cricothyroid membrane. More prominent in male, more difficult a little bit in females. The fourth part is the ultrasound technique. We have two ways, either longitudinal or transverse technique. For the longitudinal, you will put the linear probe in the midline of the neck, and you can see in the midline exactly here. This is the hyoid bone, which is a hypoechoic part. This is the cricoid, and you can see like chains of peds here. This is the tracheal rings, and the hyperechoic area. This is the air line and the mucous membrane. This is the isthmus, part of the isthmus. Okay, so when you see this one, the next step is you can put a cannula, okay, which is again like a metal part between the cricoid and the thyroid, and the cricothyroid membrane, and then you can remove your probe and mark this one. You can use it directly, or in case plan A is failed, so you'll go for the surgical rescue for the patient. For the transverse technique, again, we'll use linear probe. It's more difficult in prominent thyroid colors like in males, Adam's apple, more convenient in females. So this is the hyoid bone, And you can see here, this is the hypoechoic part, this is the two vocal cords, and this is the arytenoid cartilage here. So when you have this view, just you will slide down. So this is the view. I don't know, make it more. So this is the horseshoe shape of the thyroid cartilage. And if you displace your probe a little bit down, you'll find hyperechoic line. Okay, this is the cricothyroid membrane. Displace it more down, you will find here again hypoechoic. This is the cricoid cartilage above the hyperechoic line. It's like ring shape. So go up again to be sure that this is the airline of the which equalizes the cricothyroid membrane. And here, this is your point of insertion. This is the kit for should be used for in case of surgical rescue. It's very simple. Should be attached to each ventilator in the theater and in the emergency department. Tube, intratracheal tube size 6 can be reinforced or normal tube. Blade or scalpel size 8 or 10. Bougie and chlorhexidine for disinfection. So maximum extended for the neck. This is how to do the cricothyroidotomy, neck extension of the neck. Again, the laryngeal check, palpate the larynx, detect the cricothyroid membrane by this one or by ultrasound, whatever. Then if you can feel it, the cricothyroid membrane, so stab, rotate, insert the bougie, and then the intratracheal tube. Okay, so stab and then rotate, make the blade toward the foot of the patient caudally, and then insert the bougie, and then after that insert the intratracheal tube over the bougie. If you cannot palpate if you cannot find the cricothyroid membrane, so you can make transverse skin incision and try to palpate a small transverse skin incision by the blade and try to palpate the cricothyroid membrane. Again, rotate, bougie, and roll the intratracheal tube. So what I want to, at the end, to summarize what we said, the most important is to have plans in your mind. Airway management is not a single plan. You have the plan A, plan B, and of course, as a best guideline, there's A, B, C, and D plans for this one. So call for help, take your time, and if the patient is still stable, optimize the condition of the patient, buy time by yourself, and trying to do any surgical or intubation in a highly equipped theater, area like theater, with your assistant and specialized nurse for this one. Thank you so much.
Thank you very much, Dr. Eslam, for your wonderful lecture. We have only one question from Khalida Radwan. She says, what to do if such a patient has COVID-19 and he is positive?
Of course, we stick to the local guidelines for your hospital, but during the era of the COVID-19, of course, it was not recommended to use awake fiber optic intubation for patient during the elective surgery. But as we are talking about emergency, I'm talking about our system here in Ireland. In the E&E themselves, we are separating the patient to COVID area and non-COVID area. And if you will transfer the patient to theater, there is a dedicated theater for COVID patient. And of course, all the personnel, including the nurses, the head and neck surgeons, will be with full gear from transferring the patient from the A&E to the theater. And according to, as I said, the local guidelines for us here, after doing intubation, we have to wait for 10 minutes, and then the surgeons can come to do the tracheostomy or the surgery. And if they're planning to extubate the patient, we have to wait, of course, after this one also. So. Yeah.
Great. We have a few more questions, Dr. Eslam. So we have a question from Dr. Muhammad Ahmad Ali Ahmad. He says, can we use 14 gauge cannula as percutaneous cricothyroidotomy? 14 gauge.
If you don't have any, of course, if you have the cricothyroidotomy set, you can use the 14 gauge cannula for this one. But take care just to be cautious about to transfix the trachea going to the esophagus. So just once you feel loss of resistance, That's what we usually feel from the scalp or the blade. Once you feel loss of resistance, slide the cannula, remove the trocar, and you can start to either insert like guide wire and put the intratracheal tube after this one.
Yeah, another question by the same Dr. Muhammad Ahmed. He's asking, how can you ventilate the patient through the cannula?
Doing this one either by usually using like a high frequency jet ventilation, like Manujet or Enas, if it's available in the hospital. If not, depending on the apneic oxygenation, you just connect on high pressure of oxygen. But be cautious. This situation, even if you're using the jet ventilation, there is a higher risk for paratrauma for those kind of patients. But if you don't have any other option, you have to use this one with cautious and at the least pressure that you can use it.
Okay, we have another question from Dr. Asma Badawi. First of all, she thanks you for your lecture, as all we do. And then she said, do you recommend to give muscle relaxation in difficult intubation and easy ventilation? Do you recommend that?
Again, in difficult
do you recommend to give muscle relaxation in difficult intubation but easy ventilation, or no?
Honestly speaking, during our, if the case is an elective case, and there is an airway obstruction, I would say no, don't use muscle relaxant. Don't abolish the spontaneous breathing for this one, because you cannot guarantee that you can ventilate the patient after losing your own spontaneous breathing. Because after you put them sleep, the hypotony of the muscles can collapse this area, the 40 or 30% remaining for this one, and sometimes you will not be able to ventilate the patient.
Okay, there is a question by Dr. Muhammad Ali Siddiqui. He says, do you have any scope to use video still late for facilitating awake intubation?
Yeah, this is the awake tracheal intubation, as we said, either fiber optic, which is the most common before, but now the era is going for awake video laryngoscopy, which was proved by many studies that is easier even for the trainee to be more confident to use it than the fiber optic, and faster in preparation and easier for the trainee to get learned with this one. And the
actually, you just answered the next question by Dr. Khalid Muhammad Abdul Latif. He says, which technique you recommend for awake intubation, fiber optic or inhalation induction? You just answered this question.
Or inhalation and induction. No, it depends on the patient, but you have to be ready for all. But if you are confident, and depends on that, and this is experience. If you are confident about the awake tracheal intubation, I recommend it strongly than the inhalation, of course, for this one. And we make a systematic review comparing between awake fiber optic intubation by bronchoscopy or video laryngoscopy. And as I said, the result is more towards the video laryngoscopy in terms of the success of the first tracheal attempt and the patient satisfactory for this one.
Okay, thank you very much, Dr. Islam. That's all. Now,
Dr. Enas, please.
Yes.
If you don't mind, I want to comment and ask Dr. Islam one question.
Of course, Professor Aslam.
Thank you. Dr. Islam, you touched a very important subject today, because this subject is we are facing even every day, every moment in the OR or in the recovery, specifically with, as you mentioned, the stridor with the pediatric even. And we need meticulous and brave anesthetist, not to be in hurry or to be in panic. And I think the first step for management of obstructive airway management is to call for help.
Definitely.
For expert persons. Specifically, we have in every hospital expert persons in the airway management, and we are doing a lot of workshops in the airway management. So it is not just to give my colleagues and my residents, my juniors a home message. It is not shameful, even for us, the seniors, to call for help for any problem facing in the anesthesia, specifically for the airway, because this is life-saving. Exactly. This is number one. The second one, if you please, the teaching process in our hospitals nowadays depends on the technology. And I am not against technology. Nowadays, as we listen from Dr. Yasser and our colleagues that and before Dr. Hazem, we are using ultrasound in everything nowadays.
Exactly. Yeah.
But I am stressing about the management and the intubation, endotracheal intubation. I see nowadays for our residents, they make it easy to use glidoscope, fiber optic, and they are neglecting using the usual and the traditional laryngoscopy. So I am stressing for our residents and juniors to know the principle of the intubation first. I'm not against technology. Like the laparoscopic or the robotic surgery, sometimes the surgeon, he knows the laparoscopic and the robotic surgery, and if something happened, he cannot manage by the traditional surgery. Maybe I am an old man and I am with the tradition, or but I am using the kaleidoscope, but not to be as you. Every case, we have kaleidoscope. We may go for any place in our country or other countries or in the periphery, and we may not find the kaleidoscope or this technology. Are you agree with me?
Exactly, Dr. Assam. That's it's happened to me here in Ireland. What you are saying is really, because when I'm doing my airway fellowship in Beaumont Hospital, the protocol there is using McGraw for all patients using McGraw. And of course, this is better than diagnostics and more safe. We agree about this one. But once I transferred to Vincent Hospital, my liver fellowship now, I encountered difficult intubation. And the nurse, she told me that there is 3 McGraw only on the whole theater, and it was not available beside me. I tried 2 times and 3 times by the diagnostic. I was not able to visualize the vocal cord. So at that stage, I told her, but I feel when I'm doing this one after 1 year using McGraw, I feel still, not the confidence, but you lose a little bit the skill how to do it, Just for 1 year, I'm using the McGraw. I'm not, of course, all of you are my professors, but 16 years in anesthesia, of course, But it's very important to every now and then to keep your skills, basic skills, like the central line. Ultrasound using central line. Every now and then, every 10 patients, I'm doing one anatomical like before. In our old days, where I don't have central ultrasound for this one, just in case of emergencies, just in case you don't have it. Absolutely agree. And of course, the call of help, this is number 1 in the DESA guideline, to call of help, and this is very important, very, very important. Even the help will be the same level of you or even lower, but at least will give you second hand for you.
There are 2 more questions for Dr. Eslam, if you don't mind. One of them is about emergency situations like road traffic accident. If you have a patient that has a full stomach and is a difficult intubation scenario, what are the options available?
Spinal trauma or fascial trauma is a wide or broad topic, according to where the fracture, if there's a fracture, if he cannot maintain airway. But of course, if the patient is full stomach and you are going and suspect difficult intubation, you can do it by awake fiber optic. It's not a contraindication if the patient is full stomach. But the problem is, that's why if there's bleeding inside, it will be difficult by fiber optic because of the bleeding. It will,
of course, yes, you will not be able to visualize.
Exactly. So you can do it by video laryngoscopy. Will be more convenient if we be able to do that.
The last question for the night is the role of intubating laryngeal mask in difficult airway, and if there is a role of video assisting in difficult airway. I think you already answered the video assisting. Yes, we already answered the video assisting, so we will just give a hint about laryngeal mask.
Can I make one announcement, if you don't mind, please? Next Sunday, we have Prof. Hazem Yassin. He's going to talk to us about trauma rapid response team and ACLS. So it will be complementary to this lecture and complementary to the last lecture he gave already before, and he's with us today. And Sunday 13th of September, we have Professor Muhammad Al-Tahan. He is going to talk about his experience about video laryngoscopy in pediatric patient, pediatric obstructive airway. So this course, mega online course, will have a massive experience about regional anesthesia in airway, trauma, and of course, the endless intensive care experience by our eminent distinguished speaker, Professor Samir Ansari. He's the top star of this course. And thank you very much, everybody, today. And I am overwhelmed by this attendance and the success of the night, and wish you well, and thank you very much.
Thank you,
Thank
Dr.
you.
Saad. Thank you.
Thank you.